most people have joined. Before I give proper introductions, I'd just like to give acknowledgement of the country. We acknowledge the Palawa and Pakana of Lutruwita, who are the traditional owners of the land upon which we live and work. And we pay respects to the elders past and present as the knowledge holders and sharers. And we honour the knowledge as vital to the self-determination, well-being, resilience of their communities. As a university and as the Tasmanian Parkinson Project team, we stand strongly for a future that profoundly respects and acknowledges the Aboriginal perspectives, culture, language and history. So thank you once again, everybody, for joining our monthly Tasmania Parkinson's project. It's grown into a really lovely interactive community, and that's because of all of you. Thank you. We love your emails, we love your questions, we love to see you here on the webinars, and we're definitely open to your ideas in terms of future webinars. But I'd just like to introduce myself. I think most of you know me. I'm Jane. I'm a neurology doctor at the Royal Hobart Hospital, and I'm also a professor of neurology here at the university. And I co-lead the Tasmania Parkinson's projects with Michelle, and I'll let Michelle introduce herself.
Yes, so I'm a physiotherapist by background, and I was diagnosed with Parkinson's about 3.5 years ago. Proud Tasmanian.
Thank you, Michelle. And Bindu, we're really looking forward to hearing your wonderful presentation today. I just wondered if you might be able to click on your camera briefly and just introduce yourselves to the webinar attendees today.
Thank you so much, Jane, and welcome everybody here. Thank you, Michelle, for having me here on this project here. I'm a neurologist and I'm an adult neurologist from South India. I also work on the board of directors of the World Stroke Organization, as the Secretary General of the Indian Epilepsy Association. Very passionate about care for persons with epilepsy, with stroke, and with Parkinson's disease. And that's the reason that I founded the foundation, that is Dr Bindu Menon Foundation, and have outreach activities, which I would touch on in my talk as well. Again, thank you, everybody, and I look forward to your questions and hope I can answer them effectively to your liking. Thank you so much.
Thank you, Bindu. We feel so honoured to have you here. And I'm probably going to embarrass you now, but whenever I listen to one of Bindu's talks, I just sit there and I say, wow. Because as you will see, the work that she does is absolutely inspiring and often in really challenging situations. And I think you're an amazing neurologist, Bindu, and I think the webinar attendees are going to find particularly your work around wellness and living well with chronic neurological disorders really fascinating. So I've set the bar high there. But before we move on to Bindu's talk, Michelle and I would just like to give you a quick update on the Tasmania Parkinson's Project. What an amazing project, hey? We only started it like 18 months ago, and we've already got all of these participants. So 3,700 participants, and every week it's climbing. If you're interested to see this heat map that we've got here on the left, you can just log on to the website, Tasmania Parkinson's Project, and you will see the real-time numbers clicking up of how many people are in the project. And if you're not familiar with these heat maps, basically the colour is representing how many people per population, if you will, are involved in the project. So the red bits are where we've got lots and lots of participants. And then it goes down to the yellow bits and the green bits where there's fewer. And then white would be no participants. So as you can see, this is far from just being limited to the Tasmania area. We're really right across Australia now, which we're so delighted about. So wherever you're joining us from today, you're really welcome. We are aware that we also have participants around the world. And again, you're truly welcome to join our community. What do you get? Well, we give monthly webinars. One of these is happening right now. There's some great newsletters that go out giving people updates on what the project's doing, as well as little facts and tips around Parkinson's. There's the opportunity to take part in research. And then we also have a Parkinson's advisory group. Parkinson's Net is a really exciting project that Michelle's just launching. I don't know if you want to say a few comments about that, Michelle. What's coming up with Parkinson's Net?
Yeah, well, probably the biggest thing, well, I guess first it's a multidisciplinary model of care where we train up allied health professionals to guidelines and then make them easily findable. But the really important thing is that we're really focusing on rural areas. And if you're in Tasmania or Western Victoria, we'll be soon reaching out for people to actually be on the advisory committee for Parkinson Net specifically. So I think that's a really exciting opportunity to actually be part of the research team that drives this project.
It's a real success story, isn't it, Michelle? Because Michelle's being very modest here, but she has successfully bid for a very competitive research grant that could have gone to any project around Australia, but it's gone to Parkinson's, and it's 2.8 million, I believe, of research funding specifically to improve care for people with Parkinson's. So well done, Michelle, for that. And as Michelle said, look out for some invitations to be involved in that. But ultimately, the idea is that when that project's finished, it will be rolled out nationwide as well. So it's a really good success story for Parkinson's care and research in Australia. And then the last thing there is the MOOC, the massive open online course. And you might recognise Bindu because she was one of our stars in that. But it was basically an online course that we launched, and people took part in it and gave us feedback. We've taken it offline to analyse that feedback, and the good news is it's about to be relaunched again. I'm not sure if that's our next slide, actually. Oh, here we go. So there you go, that's the date. It's going to be relaunched on the 27th of October. Please come and join again. I don't think people can quite sign up yet, can they, Michelle?
And do pre-enrollments as of last week. So
well, there you go.
I think you can.
All right. Well, if you put that into your browser, UTAS MOOC or Parkinson's MOOC, hopefully you'll find the web page there to sign up for it if you've not already done it. It's a free online interactive educational course. There you can see Bindu right in the middle there as one of our wonderful speakers. And that map there on the bottom is showing how many people around the world have already done this Parkinson's MOOC. You can see a big red circle over Australia because the size of the circle represents the number of participants. But isn't that phenomenal? And in just 3 months, 25,000 people have enrolled in the MOOC. And that's really important because it spreads awareness about Parkinson's. And I think there are signs it's reducing stigma and improving people's understanding of Parkinson's too. So please sign up if you've not already taken part in that. Okay, I think it comes towards the end of my little bit, but what's coming up next? We've got Bindu's wonderful talk today, and then we've got another wonderful webinar coming up in just under a month by Christine Nguyen from the University of Melbourne. She's an optometrist, so an eye specialist, and she's going to be talking about visual changes in Parkinson's. So take a note of that date, but that's our next webinar coming up. Just a quick reminder, if you're keen to take part in research, log into the Tasmania Parkinson's Project website, and you should see little boxes that allow you to click on them and take part in different research projects. So this is one TAS test, which is, oh, I've gone past it. Basically, it measures hand movements, so we get you to do some of these movements or hold your hands, and the computer is measuring those movements. And ultimately, we're trying to use that data to develop a test that, one, could detect Parkinson's earlier and more accurately, and two, track change at home. So please do take part in that. I'll click onto you, Michelle. I think people have heard enough of my voice. I'll let you do the last few slides.
Okay, so we have 3,700 people or a few more, and we're really aiming for about 5,000. So please, if you know people who either have or haven't got Parkinson's, we're looking for everybody to join. and the website address is down there. You can participate, as Jane said, as much as you like, either in the research or just coming to the webinars or just getting our newsletters, but please, join us if you haven't already.
All right, well, I think we'll click out of my share there, and it's over to you, Bindu. We're really looking forward to hearing your wonderful talk. And if you would just like to share your screen, hopefully we'll see your slides. It's always exciting when we're doing live shares, so.
Thank you. Thank you so much, Shane. And needless to mention that it was so wonderful to see you there and share my experiences back there at your program. And I wish all the best. With 25,000 is a huge number, and I'm sure that it's going to increase every day.
Thank you, Bindu.
Yes, I'm going to touch on what my foundation does, and as part of, I suppose everything is visible, or the video, should I keep the video off so that
we can see your screen really well, Bindu. I'll let you know if there's any problems.
Thank you so much. So what we do in our foundation is we are trying to bridge the gaps with innovative technology and the ones which make a lasting impact on persons with neurological diseases and living with epilepsy, living with Parkinson disease, living with stroke. So we understand that it is important that one should identify the gaps in neurological care, and that is crucial for improving the patient's outcome and ensuring a comprehensive care. And some of the key gaps in this neurological care in the part where I specialize, and more so in most of the parts of the world, I suppose, is one is the limited access to specialized care, awareness and education about the disease. There is a huge diagnosis delay. It could be with patients with Parkinson disease, it could be with Alzheimer's disease, even stroke and epilepsy. The treatment gap is extremely high in the part where I am for epilepsy. In fact, 80% is a treatment gap, and that's a secondary treatment gap as well. Patients know they have the disease, but then because for innumerable reasons, or the first reason, the limited access to specialized care, they stop the medications. The post-treatment rehabilitation, I'm not sure whether there is a step care therapy in many of the diseases that in many parts of the world. Continuity to care is what I always believe in. There's a spectrum of care that one should have, and that should ensure from prevention, acute care, treatment, and then go on and so forth till they are rehabilitated and are integrated into the society. Then we have the mental health support. It's not just having a mental illness. I always presume that most of the neurological disorders at some point of time, they need a mental health support, and it is important for us to ensure a comprehensive care for that as well. We know that in a country like India, where the number of neurologists to the patient population is extremely skewed, it is important that we train and we use the resources which are available so that the healthcare providers at the primary care level are empowered to at least recognize and prevent, if not to take care. At least they should be in a position to shift the patient to a proper healthcare sector where they can continue the care, or probably lean back again to the primary care to see that the continuity of care is there. One should always be using the research and innovations, but I feel that, again, there is a bottleneck. The research and innovation in every disease is restricted to the urban areas, and the rural area is still deprived of so many things. Of course, health policy and funding always remains the area where all of us strive and work hard and try to make the policymakers believe that it is imperative that we have funding, and unless that is there, I cannot implement all the research and innovations that has happened. So in the foundation, we try to pick up certain initiatives, and one is the outreach-based neurological services. We try to build in the technological innovations in healthcare, which is easily accessible to the public. There were special initiatives and collaborations. educate and make them aware, and patient empowerment and support as well. So let us look at the Neurology on Wheels, which is the dream project and also the flagship project of the population. This goes with the idea that the reasons of travel in the rural and the urban India, which is done by the Ministry of Statistics and Policy Implementation. You could see the graph of here. You could see that in the rural sector, the health and medical amounts to almost 80% of the reasons for travel in the rural area. That means from this area to reach to the area where the healthcare sector is there. In a city like mine, I have around 20 plus neurologists. We are all scattered around in the urban areas, but none of us are in the rural areas. Having said that, India is predominantly rural. So reaching out to the rural community is imperative. And we started our Neurology on Wheels project, where I go in this van and we follow the motto of we reach, we teach, and we treat. And I would like to show you a couple of areas how we go. The we reach is the village in my area is identified from the 46 mandals. Mandal is an administrative field and a locality where we can have it. And we intimate the village head and the serpent. There is no audio there, but then you can just have the feel of how we go about it in this, in the we reach part of the Neurology on Wheels. Then we have the healthcare providers, the community health care providers. They are known as the ASHA, they are known as the Anganwadi workers and the ANMs, which are primed about the visits. And the stroke, epilepsy, and all the neurological patients are registered. With this, what we try to do is that we are trying to bridge the distance gap. The patients who are not able to reach us, we're trying to reach them at their locality, at their convenience, and trying to get the preventive feel of it, also to see that whether we can screen them and identify them and then refer them to the primary health center where they will have the access to the medications for lifelong. Then we have the We Teach project. We Teach part of the motto in the project. That is, once we reach there, we have the whole community coming down to see, even if they are not do not have a neurological illness. So we take this opportunity of spreading the awareness, explaining them about stroke, epilepsy, about the risk factors, about the symptoms and the time being brain, the stigma of epilepsy, the post-stroke care. And then we ensure it by distributing the pamphlets. And also, if we are in a local area, like if you would see this is a school area, and then people too tend to flock up in this area. So we put off those posters in all strategic areas so that they would have a chance to revisit what we have told them at some, and during the point of a Neurology on Wheels we teach. With that, we bridge the ignorance gap. The last part of it is we treat, where the patients, after being screened by my team members, they enter the clinic, that is the bus that has been devised into a small clinic. It is nothing very huge. It's just a small bus, but has got all the facilities which a neurologist needs to have. And then with that, the patients are counseled, they're given the treatment for the hypertension, diabetes, stroke, epilepsy, Parkinson, any of the chronic neurological illness. If they do not have a primary health center at their locality, they are adopted into the foundation, and then they would follow up with my foundation, where I have the regular camps for every year, and we have been doing this since 2013. With this, we are attempting to bridge the treatment gap. With this, we have visited around 58 villages, and we will be doing it tomorrow as well to one of the villages. And we have screened and educated and treated more than 35,000 people in these Neurology on Wheels camp. And there's just a screenshot of where my Neurology on Wheels bus is reaching out. There's a lot more to do, but there are only a couple of Sundays with us. And we are trying to do what best we can do with the little amount of resources and the time that we have. The next is technological innovations in healthcare. And then I would just brush through them and trying to show what are the apps that I have made. One might always want to go to the Google Play Store and try to download them. So this is a Stroke Connect app. This is an app which is which can be downloaded, but then it needs the foundation code for getting connected to us. This is a new app that we have made, which gets connected to us. People, the general public, can download, and once they have the code and they have been educated about the Connect app, they can, with the symptoms, if they have, they can just click on it and they will get, our hospital will get a message, as also a call, as also an email, as also they would be connected to the ambulance so they can reach to the hospital in time, because we know that time is brain. That's one app, and this is this stroke help app for the rehabilitation part of it, where we have 27 lessons in 4 modules with the limb, hand, and dexterity, coordination, and balance, and the vision. And we have a physiotherapist who is teaching all the exercises in all of those 24 lessons under the 4 modules. All of these apps are free to download by the patient. We have the epilepsy help app, in which you can see it is in 3 languages. That is English, Hindi, and the local language of mine, that is Telugu. And it has also got an SOS there. But if you could just click on the SOS, that is the alert app, you can feed one number. And if patients who have got auras, and students, especially when they're staying in the campus and the parents are so much worried, they can keep a number downloaded on it. And if the patient has an aura and he clicks on that, then the SMS alert, as also the phone goes to that particular person that this individual is going to have a seizure, as also it is linked to a Google app. So this becomes very convenient, as also very empowering for the person and the caregivers of the patients, that my patient is safe and I also can reach out for any emergencies. This is the latest app which we have done for a migraine, that is a NeuroCare app. So that's a snapshot, and we are working on it. And very happy to say that we have got a project grant which has been approved for a Parkinson disease, and that is a voice modulation using the AI technology. And hopefully, and probably in a year or so, we would be able to complete it and come out with constructive results to benefit the persons with Parkinson. We have special initiatives and collaborations. I would not be touching on them in detail, but we have a project called Educating Women About Neurological Disease. And the one which we are interested in is the Parkinson Disease Movement Disorder Society from Nellore, the Neuro Voice podcast, and the Stroke Prevention Campaign. We train the trainers that is taught, and tele-awareness program where there's a number where the persons can individually click on the number and listen to the recorded information about the neurological disorders in 2 to 3 minutes, the gist of it. We have a stroke mnemonic like the Be Fast in the Telugu vernacular language, because it helps me to connect to the rural local public in their own language, and it helps me to give them the warning signs of stroke. We also done initiatives and research projects with the Indian Women Scientists Associations. What can we do with supporting persons with Parkinson's disease in the community? Giving an idea about how we started with this, we have a person, Mr. R, who was diagnosed with Parkinson at 63. He was in regular treatment. He lives with his wife in a village. He comes for his regular consultation. He takes his medications and follows physiotherapy. And he's the most dedicated patient we had. He was a school teacher and he was absolutely known for his discipline. When he came in, he was on time. He had kept his papers so well stacked that I was so much impressed. When he was diagnosed with Parkinson, he was fortunate to have an access to neurologists and medication. He came straight to us, and he was well knowledgeable that where he should be reaching to. Despite following every recommendation, I saw that his world was shrinking. He stopped attending social events. His tremors drew unwanted attention, and his wife always felt overwhelmed, and they started feeling isolated. Then this is the missing link in many Parkinson cares model that we see, where the medical model really ends, but the real life continues. What Mr. R needed wasn't just treatment, and he needed community support. He needed empathy, he needed acceptance, and he needed inclusion of all that. Coping with Parkinson's disease is something which we all should understand. As healthcare providers, it's not just dispensing medications, I feel. We need to know how it is. With those, we felt that let us sort of pin down understanding the needs of persons with Parkinson's disease, which might differ in every community, in every setting, in a global platform. Let us explore multidisciplinary approaches to that. Let us learn about the role of caregivers in support system and make the caregivers a support system, another wheel to it. A Parkinson Disease Movement Disorder Society, and let us encroach on other community models. A neurology on wheels, we are trying to move to put into the perspective. Last week, we had 2 of the Parkinson disease patients who have been taken back into the foundation, and they will be taken care for their medical needs. Now we need to advocate for inclusive, sustainable support strategies. So what can we do? We, as I said, we have established in 2013, for the first 3 years, we were working towards disease, stroke, and epilepsy. In 2016, we made a small change. Then that's where we stand in the global map. That's the place where I work, that's Nellore. That's where we started this project. Before we started on, we thought that it is crucial that we really understand as to what is important. So we put down some questions. We didn't have many patients. We just had 20 patients. And these are the questions we rolled out to them to see that what is it that they feel. And this included questions like, do you participate in social or community activities? We found that most patients have stopped. They were doing well in their motor complaints. They were doing well, but still they had stopped. And what made them stop is a physical disability. They were embarrassed to move around with the tremors. There was a lack of support. There was nobody to take them around. They were not able to go for the grocery. There were transport issues because in India, we have the bus services, which is crowded. And if the person has to enter in, he needs to really work through and needs to really go through it fast. If not, then he has to use a private service, which might not fall into his logistics services. So then he comes down on his social networking at all. So do you feel comfortable going out alone in your community? They felt that they were unsafe and uncomfortable. Do people in your community understand Parkinson's disease? They felt that no, they did not have. Do you feel judged or excluded due to your conditions? They felt, yes, there's a high perceived stigma and there's a social withdrawal. Do you have access to public places like temples and shops? No, they didn't have. There were a lot of barriers, so they couldn't just go on their own. Is public transportation easy? I said that no. Do you feel lonely or isolated? Yes, high levels. Do you want to? So we thought that if we put in a support group for them, would they be happy about it? Yes, they felt that. The 15% of them, they did feel that they would not want to join. And I personally feel that's because of being clubbed into a group where they would be framed as a Parkinson's disease. And in my community, that becomes a stigma that they are suffering from a neurological disorders, something which they might not be in having a power to dispense monetary transactions, and they might go out of business. And biggest challenge no one understands me. They felt that I can't go out alone. People avoid me. I feel burdened and no local facilities. So this is just a graphical representation of what we had. And with that, we felt that we need to understand, and this is where understanding a person with Parkinson's disease, understanding a caregiver with Parkinson's disease really rolls out. So we need to know that they often come with the caregiver. They need to navigate its challenges together. So in that setting, we thought that you have a fluctuating reality. It's not really the same from what it used to be. We completely understand on that. But then we try to tell them that it's different in a day-to-day, it's different in a single day, and it's hardest to do that. But we try to tell our Parkinson's disease patients that get comfortable with the uncertainty and then try to go with the flow. We know that it's going to be uncertain. So you need to be prepared for that. There is a loss of autonomy. There's a loss of control. We know that human nature is to take control of owning our time, owning our activities. And that's the attitude which we need to have throughout the day. So think about certain things which you can own. We try to tell them that you can own the time you want to exercise. You can own certain activities that you want to do, and you can have a you can own those things and move towards self-empowerment. So you can we understand that days are not the same. There can be disrupted daily rhythms. So you need to have a lifestyle which needs to navigate, and do not cut out that things from there and make it more adjustable towards that. So there is a growing dependency, we understand, and one needs to feel and consider that there are ways how you can maneuver your role about that. Also being uplift yourself, that you can take support, you can take an assistance and move towards that, towards a new sort of independent role that you are with people around you and taking care of you. You need to have shifting responsibilities. So you need to have new roles around that. If my patient, like who was a teacher, Mr. R, he had retired, but then he didn't want to retire out of his social activities. He wanted to move out in the community. So if he's retiring earlier, he can take up some voluntary roles, which can be less demanding, but then still fulfilling for that particular individual. From the early part, when the person is there and you have diagnosed with Parkinson's disease, we as a team try to empower them with the knowledge that they can still move ahead with sort of roles which they can ensure can be fulfilling, but not too demanding. If one feels that you cannot have a regular meals with the extended family, try to fix out sometimes at least 2 days in a week where you can have walks with your family, or you can have regular family outings. You can fix it sometimes. It's the shifting responsibilities in the different areas that you might want to have. So it's the perception that one feels and one needs to have. Reflecting on your identity is very, very important. Look things in a new way. It's little different, but then it's still good. Looking back and reflecting back is also important. But that's not only the things. The game changer is that how you look yourself and how you see yourself when you move forward with this new evolved definition of yourself. So we work around this. We do not have a pamphlet to move around with that, but we just talk about the 6 areas where we ask them to. Then we look at the multidisciplinary approaches. So we just put a slide where we felt that these is where we felt that these are the type of practices one can have. So what I am working in, where I am particularly functioning is the consultative practice that you can see here. See here. But then what I would be looking forward is an integrative practice where we have a feedback approach as to where the patient has gone. The person with Parkinson's disease has gone to several areas. He has gone to an occupation, he's gone to this. So I get a feedback whether he's okay or not. So this is a busy slide, and this is how we are working with the community support with the group for Parkinson's disease, where we need to have an assessment. We need to have a leadership and a core team. So I have a team where I have physiotherapists working with me. I have patients, I have trained volunteers who are working with me. I have caregivers who are helping us out in activities, in managing the Zoom, in managing the spreading out the information, putting out in the chat box. Even small things do work well. And even the small things help them to get empowered that they are working, they are also doing something in a larger framework. So you need to have a safe and accessible venue. You cannot just keep anywhere. You cannot keep changing because it becomes difficult for them. It needs to be on a ground floor. It needs to have a wheelchair ramp. It needs to have clean restrooms for that. You need to have options for hybrid because that's what we have done now. We have gone hybrid. We have in fact gone completely online because that's how it helps us. You need to have a structure and format. You cannot just randomly post that you're going to have it suddenly just 2-3 days. You give a time and just post that we're going to have a webinar on this time. So we have made a structured format. It's on a Monday. It's on 7 p.m. So they know that they need to align all of their activities to that particular time. You need to have partnership, you need to have training and resources. We see to it that the patients, the caregivers, and the and the volunteers, as also the coordinator, is also trained. You need to have funding, sustainability, publicity, and awareness, because it might not reach the persons with Parkinson and their caregivers. You need to have a monitoring, feedback, and then legal and ethical considerations. So this is a screenshot of what we actually do. We do a gait tree education. We do a balance and flexibility. We boost the stamina and the heart-lung fitness by aerobic capacity. We do the moment initiation. We educate them about functional independence and also train them about the home safety. So we had all of that. And then in 2016, we started the first Parkinson disease support group, which were a couple of patients around. And we started doing the education and capacity building from there. And as you can say that we started educating the ASHA, these are the co-workers in the rural public, and we started giving them pocket guides and symptom cards and trying to reach out to them. And this is a method which is scalable, this is cost effective, this is empowering, and this is sustainable, because they are going to be there in the rural area. They are particularly entrusted with the women and child care, but then they visit the houses. So we ensure that not only Parkinson's disease, but we also look at stroke, epilepsy, and Parkinson's disease in different timings and time zones. So this is the educational program that we do. You can see that the ones in the uniforms are the community health workers. So we reach out to them with posters, pamphlets, educational programs, slides, if they have a PowerPoint as well. And we reach out effectively, sustain, and it is a continuous project that we are running. Learning about the role of caregivers and the voice, putting out their voice. So we have the Neuro Voice project, where we invite patients, caregivers, and question out to them. It's a small one. One can go into the podcast and listen to them, that how much what we realize and what they feel sometimes is so tangentially different. And it's an eye-opener for us as well. And that helps us to remodulate our programs in effective ways. Reaching out to the community through television, breaking the silence about Parkinson's disease is absolutely important. And we feel that we do not leave any stone unturned. So we have these modules which are there on the website, which can be reached, which can be listened by any person. We have broken down into several parts and small groups, like what is the importance, what is Parkinson's disease, who is affected, and so on and so forth. In any of the World Parkinson Day, we go in a massive way, where we take the print and the electronic media and see to it that we reach out. We also do training programs and training sessions for the physicians, as also the PharmD community, because they are another group of community who are healthcare providers, and they align with and they join the team of neurologists, and they can be an extreme help for us to navigate certain of the complex problems and issues around talking, communicating, reaching out, making a group. And we have done that, and it has helped us tremendously. As the voice is not there, but then we take persons with Parkinson's disease who have been there in our Parkinson's Disease Movement Society group. Oh, this is, yeah. I'm sorry, this is too little. So you can see that we give them a voice, which helps other persons with Parkinson's disease to understand that they can also talk out, they can be in public forums, they can be on the TV live, and they can talk and listen, and they were listening to them. We had so many requests from the other persons and caregivers that we were so happy that, and we thought that we should do this more often. And we thank both of our patients so much for the boldness to come out into the public and talk to them. So then in 2001, Dr. B.S. Singhal had started. In 2018, we got what we were not having is the partnership, the training, and the funding and the resource. The funding and sustainability is still not there, but the partnership and training and resource models we have. So we have a mail, which there is a group. and their mail with scheduled topics are already, like you can see, week first, 7th March, it's a warm-up, oromotor difficulties, cool down. In week 2, there is a finger and hand exercises and and so on and so forth, sorry. So we have this mandala art therapy, Diwali lantern making. This is a Sanskrit word that means circle. I've just kept. So you can see that it needs precision, it needs concentration, it needs interest, it gives enjoyment. So this is 2017 what we were doing, and we continue to do that. You can see how lively my persons are, having made those creative, which needs a eye-hand coordination. It requires posture, attention. It encourages creativity and reduces the negative feelings for that. We go on and we do trunk and body exercises in the group. You can see that patients are taught with color paints and they're made to draw and paint. You can see one of the patients' beautiful drawings, which she came out. We were not even aware that she can draw to that magnitude. And you can see that it's so beautiful. And we have this local, you can say that local indigenously made pens with some rubber inking. So it is very easy for handling the pens. And you can see that the patients were able to write better. And he has very effectively written, "I am a good boy." So these are some of the programs that we do. And you can see my persons with Parkinson disease getting empowered. We use colors, we use noise, we use designs, we use comradeship, and we use ideas. We ask them to come out with more and more what you can help us, and we can make this as effective and better. You can see that how beautifully they have pictured out my window with that multicolored drawings. We went online when it was COVID struck. We didn't know what to do. My patients were very finding it very difficult. They reached out to us at what we could do, and the whole globe was going online, and we felt that this is the one we could do. And you can see that it has again become very easy, because in the confines of the house, in the close quarters, they can get engaged to us. And we started off, we had a hiatus of around 6 to 8 months, I suppose. And then we went online and we do all of the exercises, and they are comfortable with it. I will leave that out. And with that, I should say that together we can make life better for every person with Parkinson disease, and we can include more and more persons, and we can see that living well with the disease, understanding with the disease, and coping with the Parkinson disease becomes much, much better if we are aligned and understand the needs and the challenges of the persons with Parkinson disease. If I'm allowed to, and this doesn't have an audio again, but you can see these are my patients. We just did a small video, and you can see that they are moving along with us. In fact, we are moving along with this, and all of us are happy. Thank you so much. And it's never a single effort. I thank all my team members, my coordinator, the Parkinson Disease Movement Disorder Society for sending us regular modules, my patients, my caregivers who put so much of faith and trust in me and align with me for all of the activities and the initiatives that we move forward. Thank you so much.
Thank you so much, Bindu. That was absolutely phenomenal. I don't know where you find all the time. I mean, it's like you're doing 4 people's jobs.
Gee, sleep.
Bindu, we do have some questions, and I'd just like to remind all the attendees, we love your questions. If you would like to ask a question, please just type it into the Q&A box at the bottom of your screen. We will try and get through as many as we can. We might not get through all of them, but we'll do our best. So Bindu, is it all right if Michelle and I ask you a few questions? These are coming from the attendees.
Oh, I thought I was supposed to type in those answers.
Oh, no. If you could just answer them on screen, that would be wonderful. We will read them out to you, we'll get through as many as we can. So people are saying it was absolutely inspiring. Patricia's interested to know, how is your work financed? Because there's a lot of work going on there. Are you able to tell us a bit more about that?
Absolutely. Thank you, Patricia, for that question. The foundation has had two major fundings from the World Federation of Neurology. This was for an intervention program for the neurology on wheels, and has also had funding from the American Academy of Neurology. And I thank both of the funding agencies for having done that. We do have small fundings sometimes from philanthropic people who just chip into me. And then I should say a portion of that comes from my self-funding.
Wow, that's incredible, Bindu. I'll just ask one more question before I hand over to Michelle, but can you give us, the attendees, an update on how many people are there in India? Tell us a little bit about India.
So India is a huge population. I suppose 2 billion is the population, and the population does, and the whole sector too varies. Some of the states, we are distributed into 23 states, and some of the states are densely populated. It's like if you'd see in Kerala, South India, it's a small area, but it is very densely populated. The place where I stay is Nellore. It's a semi-urban city area, and the population is around 10 lakhs. I suppose that would come to 1 million population. So we are catering 1 million population. We have around 20 neurologists who are working here. But then there is another skewed deviation, as I just mentioned. We have 80% rural and 20% of urban, but we are 23 of them in urban and none of them in the rural. So that's how it happens. And just to give a perspective of the disease as well, Jane, there has been an epidemiological shift of lately, and we are seeing less of communicable diseases and shifting towards the non-communicable diseases also. But then some of the areas are fighting the battle of the communicable as well as the non-communicable diseases. So you can see that the burden of the healthcare is very, very high. So to go for preventative technologies, while we are still battling with the communicable diseases, like we would have malaria, we would have dengue, we would have the meningoencephalitis during the seasonal variations, then to reach out at that point of time for preventive aspects, preventive neurology, sometimes becomes a challenge for us. We try to do what's possible in the best of the time and the resources given.
Thank you. I might ask the next question if that's okay. And lots of people have said how inspiring that was. There's another Michelle, and she's asked, how many allied health therapists do you have access to on your team to support your patients? And I'd also be really interested, do they go rural in the bus with you?
So I have a team of volunteers. Though the volunteers are not, they keep changing. So there are a bunch of 20 volunteers who at every neurology on wheels and my camp, they would keep changing. So it's a task for me. So prior to the neurology on wheels a week, I need to identify who should be. So I put on in my chat box, and then they will say, yes, this time we have these 10 members. Then I have a physiotherapist who is also a part of the foundation who comes along with me. Sometimes I'm accompanied by a medical officer as well. I have a D-Pharm student who also has been trained in neurology who works along with me. I have a team of nursing professionals, nursing students, I should say, around 7 to 8 of them who come along with me. Again, I want to thank all of them. They are volunteering for my work. They are not paid employees for me. So this is the team I have.
You obviously inspire them to come along.
Yeah, I'll ask the next question, and it's about the technology. I mean, the apps that you were showing were amazing, Bindu. Patricia is also saying, is there an issue in terms of how many areas have access to that technology to be able to really access the amazing apps that you have? So perhaps that might be in terms of how many people have smartphones, or is internet coverage across India pretty good?
So that's a very good question. So while we were making the apps, we were also aware of the fact that which is the population who is going to get benefited out of it. And surprisingly, Patricia, that we found that though the resources for health are probably low, but India has got an excellent internet connectivity, even in the rural areas. The government has ensured that. And the number of mobile phones probably closer to China, everybody has got a mobile phone as well. So if one individual in the family has got an internet access, that should be sufficient to have access for the stroke health and the stroke connect and the migraine help app. Of course, the epilepsy help has to be in the person's individual's phone because he needs to have the SOS technology. He needs to put down all his seizure activities, seizure diary, and his medication changes. But then we have seen more or less most of the patients, I should say around 2 or 3% of mine have not been having an access to internet, but then all of them, even in the rural sector, do have that. And that's amazing.
It really is amazing, and it shows the reach, doesn't it,
Yeah.
of a low-cost technology, which is, using smartphones. They're very innovative.
So I might want to put there, Jane, that I'm a part of the South India. So we might be having certain areas in the North India, which might, in the rural sectors, which might not be as empowered in the internet connectivity. So it depends upon the states as well. So how educated and how the technology services the government has given access and how logistically it is accessible to them. So it might differ in the northern parts of the country.
Yeah, we have a big disparity across Australia as well. That's great. I might ask the next one. So this is from Mutinta, and they've asked about the shortage of caregivers, and it's very hard to get people to look after people that have Parkinson's as the other caregivers need to rest. So have you got any good ideas about, I guess, increasing the number of caregivers? And I wondered, in India, are family more involved, or are there paid caregivers? Can you tell us a little bit how that works?
Thank you so much for that question. That's a big challenge, and that continues to remain a challenge. Paid caregivers are definitely there, but then logistically it doesn't help for the patient at all because they are not to the level that the person with Parkinson disease can afford. If it is a joint family, if it is a village, it's a little easier for us to navigate this problem because in the villages, it's a close-knit community. The house is a little closer by, and they tend to more interact and sit outside and under the trees, under areas where people can, if one person needs to go out, so I tell them that share responsibilities, have a timetable where the other person can chip in that form. In the urban areas, I'm finding it difficult because it's becoming more nuclear, and the neighbors is something which we cannot get, and paid caregivers. I'm sorry, I don't have an effective answer for that, as I take it one-to-one with the person and try to find out whether I can give in some support and some advice which can help them and align with their day-to-day activities.
That's so interesting. So in those kind of rural areas, potentially people have more support because of the family and the community and maybe less loneliness potentially.
So I just wanted to chip in. So for some of the patients, I also say that we have religious places like temples. So in the morning hours, I ask them to be there because there will be so many people around there. So they can be there for an hour or so. And that is the time when the family member can get their groceries, get other things, and there would be somebody to look in there. So I do some small sort of navigation according to the area that they are in.
I'll ask the next question. We have a question from Cassie asking, how do you get younger onset people with Parkinson's to engage in the support groups? Because sometimes when you're a younger person and you go to a group and you see a lot of older people, that can be a little confronting or harder to engage with. What is your experience of that, Bindu?
Kathy, I completely agree to that. We ourselves felt that because they found it extremely difficult to engage with the population who was definitely older to them, and they were little fallouts. So what we did in this situation is that we gave them responsibilities. We made them the team leaders. So it was not as a person with Parkinson that they were engaging. They were a volunteer and a group leader whom they were engaging. So we tried to navigate that, and we have found that that really helps. Might not help with everyone, but then it really helps, giving them responsibilities and making them a group leader. If not, let us say if it is for a art activity, we tell them that he is going to be part of creative or art activity. So he is going to decide where the things are to be bought, what are to be bought. We'll tell them, but then he is going to put it in the group. He is going to do all of those and channelize and get there. So he doesn't feel, and he gets motivated. And I find that helps a lot, if that's okay.
It's peer support, isn't it? You know, and
Yes, absolutely.
it's very powerful, and we very much use that on the MOOC as well. People
Yes.
with Parkinson's explaining the condition to others.
Yes.
Excellent. So Harley has asked, do you have any evidence of environmental influence of Parkinson's in India? That's a very topical topic at the moment.
Yeah. That's interesting because me and Jane were touching on the topic 2 months ago. You remember, Jane, that yes, we have a huge pesticide use in our country in the rural sector, and we might be looking at secondary Parkinson that areas. But I'm not sure of a study that has been really looked at whether they are really having it, but then it is definitely there. I'm not sure about the air pollution, that's part of it, how much it is the exhaust and the combust from the vehicles and the fumes with the air pollution connected to it, how much in the long run that is also going to make a change, and that's going to increase the incidence of Parkinson disease. But then, yes, it definitely needs to be considered in the long run.
We are actually at time, Bindu, and I don't want to put you on the spot, but I actually have 2 more questions, and I wonder if you might have time for those, if that's okay with you.
Yes, sure.
We do try and finish on time. One question is from Michelle about, do people need iPads or similar to access your online telehealth services, or can they access via a phone?
Oh, yes, Michelle, they can access via the phone. But we do encourage them to have a laptop because that gives a wider picture of all their friends who are there on the screen. So they can, in the phone, it becomes difficult, but most of them, they don't have. So we ask them to access it. They are getting more and more comfortable with it.
Thank you, Bindu. And before the webinar, somebody emailed a question, which is somebody wants to know about, are you aware of any connection between cancer, epilepsy and Parkinson's? Because this particular person has all 3. And recognising you're also a real expert in epilepsy, they'd just be interested to hear your thoughts on whether there is a connection or whether it's just bad luck, really, to get all 3.
Oh, I'm really sorry to hear that. Yeah. And I am not sure and aware of shared risk factors of all the 3 conditions, except cancer and Parkinson disease, maybe at that. Yeah, no, I'm not really sure of, are you, Jen?
No, I wasn't really either, Bindu. To me, it sounds like they're probably separate conditions. I mean, the only, you know, as people get older, they get a little bit of hardening of the arteries sometimes, which can increase your risk of epilepsy, and you can get something called vascular Parkinsonism. But otherwise, I struggle to connect those, actually.
Yeah.
You know.
Yes.
Okay, well, I think we should wrap up now. We're extraordinarily grateful, Bindu, to have had your time and your expertise today. Michelle and I now want to come and visit you in India and learn from you. So watch this space.
Maybe we could have a sister project or something.
Seriously, Bindu, we're very, very
It was
inspired.
fantastic.
And Michelle and I have talked about maybe doing a little road trip round Tasmania or other rural parts of Australia, but we've got big shoes to fill if we do anything like you. So thank you so much. I can tell from the comments and the questions, everybody has found your webinar fascinating, and there'll be many more people that will watch this as a recording as well. So thank you so much, Bindu. And just to say to all our attendees, if you would like to hear more from Bindu, she is one of our stars on the MOOC, which will be reopened again at the end of October. I'll let the final words be from you, Bindu, and just thank you once again from Michelle and I and everyone at Tasmania Parkinson's Project.
Thank you so much, Jane and Michelle, for having me here. And every time I talk to Jane, the questions that pour towards me always gives me a thought, and I suppose always gives me an area where I can do some more improvements. The questions are by all the delegates have been tremendous. I suppose there are areas where we can make some more changes. There are lacunas. Thank you for having me here and for the extremely wonderful work that you are doing. Keep shining, keep inspiring, and keep empowering. Thank you.
Thank you, everyone. Have a lovely day.
Thank you.
Goodbye from all of us. Bye-bye.
Bye.